Hello, everyone, and welcome to today's webinar, an expert guide to mastering upper face injection with LNC. Before we get started, I would like to go over a few items so you know how to participate in today's event. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions panel of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of today's presentation. Please note that the clinical photos in this presentation are for educational purposes only and should not be reused, kept, or shown to other people. I would now like to introduce our three speakers for today's webinar. Our first presenter is Dr. Xiangli Lin, a dermatologist from Taiwan. Dr. Xiangli Lin is a board-certified dermatologist and one of the most renowned speakers in the field of aesthetic medicine in Taiwan. Our second presenter is Dr. Isaac Wong, an aesthetic physician from Singapore. Dr. Wong is the first Singaporean trainer, international LNC and silhouettes of trainer, and pioneer member of the first Asia advisory board for LNC. And last but not least is our beloved Dr. Amanda Ong, cosmetic physician from Melbourne, Australia. Dr. Amanda Ong is known as the Queen of Collagen due to her extensive knowledge, advanced skills, and love of collagen stimulators. Now, let's begin with Dr. Xiangli Lin.
Thank you, Alex. In this part, I'm going to talk about forehead injection with LNC. Okay, I'm a dermatologist based in Taipei, Taiwan. Before I begin, I'm going to talk a little bit about the injection book, LNC and LNC Injection Book, the Expert's Guide. Now, let's take a look at the short video. The injection book is a book that we share a lot of information with you. We compile quite a lot of information, including how to use the product safely and how to inject beautifully, and how to, also give the up-to-date information on LNC, including its mechanism of action. And in the book, we tell you how to do the assessment and to correlate with the relevant anatomy information and the aging process. And of course, if you care for combination treatment, we tell you the principles and the modalities and how you should combine LNC with other treatment. And last but not the least, we tell you how to prevent and even to treat adverse events associated with LNC. This is the book myself with other 4 international key speakers that we share our experiences with through this book with you. Okay. So you can see the book content. We give you the introduction of LNC and the anatomy information. We give you the aging process that takes place in different areas of the face. And also we tell you how to select the patient and how to prepare a patient. Of course, the injection techniques for different areas, different compartments. And we also compile quite a few cases with the purpose of beautification, prevention, and rejuvenations inside. And also we share with some cases that we use combined treatments to cover, to treat these patients. And of course, we tell you how to avoid and to manage the adverse events. So if you are interested in the injection book, please scan the QR code you're seeing now and get more information. All right, now let's move on to Elanze. I'm going to talk a little bit, give you a short introduction of Elanze. We all know that Elanze is composed of 70% of CMC gel that acts as a carrier that carries PCL microspheres into the skin. And then for the 30% of PCL microspheres, it stimulates the growth of collagen. Both of them are completely biocompatible and bioresorbable, and then eventually they are excreted out of our body in the form of CO2 and water. And the degradation time of PCL chain is strongly associated with its length. Namely, the longer the chain, the longer time it would take to be fully degraded. So for Elanze S, its fully degradation time is roughly 12 months, and for Elanze M, it's around 24 months. But the differences between Elanze S and M are all enclosed within this PCL microspheres, which means that the viscosity of S and M, or the rheology or the other physical properties are exactly the same. Unless you take a look at the brand, the labels on the packages, you cannot tell the differences when you're injecting them. So that's also very important for us to know. And 30% may not seem much, but under microscope at this magnification, we see these microspheres are suspended evenly in the CMC gel, and through collagen stimulation, the collagen will gradually forms like a scaffold structures in the location that we place the product. So that will resupport the soft tissue, even reposition the sagging soft tissues, and then eventually we get to correct the aging signs. After placement into the skin, CMC gel will provide the immediate feeling effects, and then through immune reaction, PCL will gradually stimulate the growth of collagen. Usually within the first 2 weeks, we call it a short acute inflammation stage that confines to the product into the implant site, and then we have macrophage and through because the particles cannot be phagocytosed. So through the gradual stimulation, we will have initial collagen information at around 6 to 8 weeks, and then gradually it stimulates the collagen production more and more, and we get quite a lot of amount of collagen type 1. So the idea when we are using Elanze, the idea is to let the product have the larger surface area to be in contact with this tissue, the better. So because when the product has larger surface area in contact with the tissue, then we will have a better stimulation of collagen. So to use the product well, we need to place the product in multiple plane, in multiple areas of the face to correct the aging sign. In this case, I used 5 syringes to treat the upper face and the mid face mainly, to restore the facial projections, to correct the aging signs of the mid face, and of course some of the nasolabial fold. And we can see through the distribution of the product on the upper face and the mid face, we are able to see the improved facial projection of the face, and especially the forehead and the mid face. And we also see the tear trough improvement, not because we directly fill up the tear trough. Instead, it's because we restore the anterior projection of the mid face. And without directly treating the mid face and the lower face, we see the without directly treating the lower face, by only treating the upper face and the mid face, we see the auto improvement of the lower face, which is the jawline definition improvement, and also we have get a slimmer lower face after injection. And when we observe this patient all the way from month 2 to month 6, 1 year, and to month 24, we see a lasting results from Elancey due to the collagen production. So in the mid phase, we see all the way up to month 24, we see a still very nice improvement in the anterior projection, and we see the jawline definition maintains quite well. And of course, the upper face, we see a better projection, improved skin quality, and of course, the tail of the brow is a bit lifted. And speaking of the upper face, which is the main topic for today, one thing I love a lot about Elancey is that it is a product that is very suitable for the upper face treatment. In this publication, Dr. Hong from Hong Kong shows us that from month 3 to all the way to month 24 after injection, we see a very stable gaze scores improvement in the forehead. So the product, when we are using the product to reshape the forehead, to correct the aging size of the forehead, the result is still very stable and long lasting. So to treat the forehead, we need to understand the aging process first, so that we would know where to place the product and how to place the product. Before we dig into the anatomy, we go through the poll question first. The poll question is, which of the following is the main injection plan of the forehead for Elancey? Layer 1, layer 2, layer 3, or layer 4. So you can answer, you have some time to answer now. Okay, let's take a look at the result. Okay, I see the result. Most of you answered layer 4, 45%. Some of them prefer layer 2. Okay, the answer is layer 4. I will tell you why in the following slides. Okay, when we are injecting the forehead, there are two main factors we need to take into consideration. One is the skeletal features, because for different ethnic groups, they have different skeletal features that we need to take into consideration. And because the ethnic features or skeletal features, it also influences the way aging size shows in the aging process. So for example, we Asians tend to have flatter foreheads, more retreated and underdeveloped mid face and lower face. So the central part of the face seems to be an area that we need to pay extra attention when we are treating the patient. And you can see from this description here that the forehead of Asians are usually a little bit slanted backward. That means that we tend to lack some projections in the upper third of the forehead. So this area is an area that we probably need to pay extra attention when we are reshaping or rejuvenating the forehead area. So this is one of the factors what we need to take into consideration. The other factors that, of course, is the aging process. In this case, I use 6 syringes to correct the aging size of the upper face, including the forehead, the temporal areas, and also some of the product in the medial maxillary area. And we see after a better projected and central part of the face, we see a fuller forehead, either in week 12 or at week 56. And the facial shape has very nice change after the treatment, and the result is lasting because of the collagen stimulation. The other factors, as I said earlier, is the aging process. So in the aging process, we lose some bony support, we lose some fat, in the temporal area as well, or lose some fat in the forehead. So for the bone because of the bone remodeling, there is loss of forehead convexity. We see more concavity in the forehead and also more forehead lines when we age. And also we lose the temporal width due to the fat loss and also the bony change. So the temporal width becomes a bit narrower and narrower as we age. And of course, there is a significant shape change of the bony orbit when we age that will lead to a drooping of the lateral thirds of the bore, or coupled with the influences of the temporal width loss. There is also another frequently seen aging sign called temporal hooding. Temporal hooding means ptosis of the skin of the temporal region. And temporal hooding is the result of ptosis of the roof, the deep fat of the brow area, and also tissue layer 1, 2, and to a varying extent layer 3 of the interior part of the temporal region. So to correct temporal hooding, that means that we need to treat volume loss in this area to correct the temporal hooding. And the reason we have temporal hooding is that the frontalis over the lateral third of the lateral brow is usually absent. That is also one of the factors that contributes to temporal hooding. And there is attenuation of the periorbital septum over the lateral part of orbits that eventually allow further ptosis. So after knowing all this information, these pieces of information tells us that when we want to treat the aging of the upper face well, we need to treat the aging process, which is the deeper plane of the forehead or even the temporal area that allows us to resupport or restore the projection of the foreheads and resupport the soft tissue. So we get to compensate volume loss in over the forehead and temporal area, and then eventually we get to reposition fat. So we are not just filling the hollows. So this is quite a piece of important information that we need to know when we are treating the upper face with Elance. And we cannot treat the patient well without knowing the anatomy of the face. So generally, we have several layers of the face, and for the forehead area, it is also the same. We have the skin layer, we have subcutaneous fat, which is the superficial fat in layer 2, and then below it we have frontalis muscle, which is the smooth layer of this area, and then below it we have retaining ligaments, spaces, and deep fat compartments. And then comes the periosteum and deep fascia, and then we have the periosteal plane. So layer 4 is the main area that we use to resupport the soft tissue above. In these publications, we see we not only have superficial fat in the forehead area, we also have deep fat pad in the forehead area. So when the dissection was performed in the subperiosteal plane, we're able to see the compartmentalized areas that are dyed in different colors, in the blue and the red. And then between the compartments, we have septums. So it tells us not only we have deep fat pad in the forehead, but also we have septums between them. So when we are injecting the forehead, we also need to make sure that our cannula is treating all the different compartments. So if we are placing the product only on the lateral compartments, there's no way we can massage the product through the septum to the central fat pad this way. So we have to make sure we covered all the different compartments so we are treating the forehead. And as for the blood vessels, there are two major arteries in the forehead, which is the supratrochlear artery and the supraorbital artery that exit the supratrochlear foramen and the supraorbital foramen, and then they goes up when they reach above 1 centimeters away from the orbit, it goes superficially to the layer 3, which is this mask layer. So that also tells that when we are treating the forehead, when we're injecting the product on the level of layer 4, it is relatively safer because it's a relatively avascular areas that allows us to place the product safely. And it also makes more sense because it's the areas that we lose its volume more in the aging process. And sometimes when we're treating the forehead, we also need to pay attention to the temporal area because sometimes they just go hand in hand when we are reshaping the upper face. So I'm going to talk a little bit about the injection layers of the temporal area, and Dr. Isaac will cover some more in his presentation. So in the temporal area, there are actually 3 main layers that we place the fillers, which is layer 2, the subcutaneous fat, layer 4, the interfascicular layers, which is also the deep fat of the temple, and also layer 9, which is the supraperiosteal plane that we place the product with, treat this area with fillers. But for different plants, they seem to play different role in the aging process or the aging side. They contribute differently to the aging side. So for example, if we place a product in the supraperiosteal plane, we mainly use it to correct the temporal hollowing or to improve the temporal crest visibility or the lateral orbital rim visibility. And sometimes we can even use this plane to reposition or to lift the tail of the brow. And if we inject the product in the interfascicular plane, it also allows us to correct some of the temporal hollow. As a matter of fact, for some of the patients that really have severe hollowing in the temporal area, we need to treat both plane to have a better correction of this area. And we can also use it to reposition the brow, to lift the brow, and we can even use it to correct, to improve the cross feet. And in some cases, the lower cheek fullness is improved as well. And for the subdermal plane, it's mainly more functional or more useful for the mid face and the lower face, although sometimes it can be used to, this plane can be used to treat the temporal hollowing, but mainly we use the supraperiosteal plane and the interfascicular plane. And for the subcutaneous plane, it contributes more to the lower cheek fullness and the jawline contouring. So in short, for the subcutaneous plane, the layer 2 is less recommended for the upper temporal area. And for level 4 is recommended for the upper temporal area. And when we are treating this area, we can make the entrance point right on the bone. And then we medial to the temporal crest, and then we use our cannula to go laterally, then we will reach the correct layer, which is the interfascicular layer, to treat this area. And for layer 2, it's mainly used for the lower temporal area. So it's used to precondition the soft tissues of the central middle face prior to the treatment. And of course, if it can also be used to enhance the appearance of the jawline, the brows, and sometimes even the labiomandibular sulcus and so on. And for the supraperiosteal plane, it's recommended for the upper temporal area to reposition the tail of the brow. Now, let's take a look at the recommended injection techniques for the forehead and the temple. So we already know that layer 4 is the main plane that we place the product. Generally, for the whole face, if we are treating the subdermal plane, we use linear threading technique or fanning or crest hatching, and we are treating the supraperiosteal plane, we do bolus deposition, and we can either use 25 gauge needle, 27 gauge needle, or you can use cannula 22, 25, 27 gauge cannula. But for the forehead, it's a little bit different. I will show you in the following slide. And for the points of entry for the forehead, I think I want to point out one thing that you how to choose the point of entry. First, you need to mark the areas you want to treat. You will have to mark different small areas, because for each of these small areas, you should allow your cannula to cover long enough to cover the distal part of these areas, so that when you are treating each small area one by one, you can always use your cannula to reach and cover the whole each particular small area you're treating. And some of you may prefer to pre-mix some lidocaine before injection. And I need to remind you that 0.2 is the maximum amount for each syringe. I have heard quite a few stories from other doctors that they mix more than 0.2. And when you are mixing more than 0.2, it is very likely that the viscosity of Elance will suddenly drops, and then you are no longer injecting Elance, you're injecting some diluted products. And when you're injecting an over-diluted product, the PCL is no longer well suspended in the CMC gel. That will eventually increase the risk of nodule formation, which is not an ideal way to use the product. And for the injection technique for the forehead, you can use either 22, 25, or even 27, but there are pros and cons. For 27, it is easier for us to make sure each line is smaller, and then that will make each line smaller and to spread the product evenly in the injection plan. However, of course, we need to, because 27 is relatively smaller. So when you're moving, we have to make sure that you're moving slowly to avoid the vascular damage or to irritate the periosteum, which will make the patient less comfortable. But for 27 or 25, each line will become a bit thicker. So you have to make sure that when you are injecting, you are keep your needle or cannula in a constantly moving fashion, so that you will have lines instead of different boluses of different sizes. So this is very important, because if you are using a larger cannula and then you are creating so many boluses, then that you will also creating irregularities at the same time. So I will give you a quick review of the key steps of injection. Step 1, what I usually do is to mark the area of volume restoration. In this case, her right side is shorter and lower, so I usually would place more product on the right side than the left side, and then I mark small areas on the upper third, middle third, and the lower third, and to balance the left side and the right side, I would add a small areas superperiosteally at the tail of the bra on the right side, just to make sure that we get a balanced and symmetrical result. And then we determine the entrance point. As I said, we need to make sure that when we are advancing the cannulas, we need to make sure that the cannulas are able to reach far enough to the distal end of this small area. and then we treat the areas one by one. Usually it's preferred to treat from the upper area to the lower area. So when we are treating the upper third first, that will usually reduce the severity of the aging signs in the middle third, and then that will in turn changes the amounts needed for these section, so and so on. And then after that, we do molding to smooth out the area we have injected. And there are some tips to avoid irregularities. The size of the cannula is one factor. And then when you are doing fanning, you have to make sure that there is no excessive amount product at the proximal ends of the lines, because if you're using the larger the cannula, this situation may occur even more frequently. So it's better when you are injecting, you're placing each line, the proximal part, you should taper the amount so that you will have a more even distribution. So let's take a look at some of the cases. This is a case that I do the full face with 8 syringes, but for the forehead, I use 2.5 syringes to treat the forehead. For the temples, I do the superperiosteal placement, and then I use cannula to with the one entrance point in the center, the upper part, close to the hairline, and then 2 other on each side to place the product horizontally. And this is the result. 6 weeks after 8 syringes fall phase, we see a better projected better projection in the forehead after injection. And then we also see a lifted brow due to the volume restoration in the temporal areas and the lateral part of the forehead. And this is another Asian case that we have some concavity in the forehead, and also due to fat loss and bony changes, we also loses the width in the temporal area. And after 3 syringes, I place superperiosteal in the temporal area and a subgaleal layer with cannula in the forehead. This is the result I get after 3 syringes. And because the result is really long lasting, we see even at 50, 60 weeks after the treatment, we still see the result is quite good and better than the baseline. And in this case, I treat not only the forehead, but I also place a little bit of the product in the upper temporal area and the lower temporal area. And when we appreciate the after images, we are able to see, due to the change of the facial proportion and the improved anterior projection of the face, generally the face shape looks a bit smaller than the baseline. And because of the placement of the product in the lower temporal area, we also get to see the improvement of the jaw line or the lower face after we treating the upper face. And this is another case that I followed for up to 3 years after placement of a Lancet S in the forehead and the temporal area. And we can see that 1 month after injection, due to the fullness of the forehead and volume restoration in the temporal area, the facial shape becomes more oval, less skeletonized, and all the way to up to 3 years, the result is lasting, and the result is still quite obviously even 3 years after the injection. Okay, let's take a quick look of a short demo video. So in this video, I marked some small areas, and then these are the cross areas are the entrance point I'm going to use. And as I said earlier, I will usually begin from the central part of the face and the upper third, so that we after completing the upper area, then we will know the exact amounts we will be, the middle or the lower part will be needed. So I go in from the entrance point along the hairline. So in this case, I use 27 gauge needle. When you are making the entrance point, you need to make sure that the tip of the needle hit the bone. And then when you are introducing the cannula, you need to use your other fingers to create spaces to allow allows you to advance the cannulas forward. That will help us to avoid irritation of the periosteum and then to avoid vascular injury. And when you are reaching the distal ends, you have to use your other fingers to feel the needle to make sure you are hitting the right place, and then you place the product. And then when you are placing the fanning or lines, you have to also at the same time to keep your needles moving so that you will have the lines of even sizes and distribute the product evenly to avoid irregularity and especially the nodules at the entrance point. So this is very important. And then after I finishing the upper third of the forehead and a little bit of the temporal area, I usually go to the areas above the brow and also the areas that quite the temporal areas that the adjacent temporal areas to the forehead to cover to smooth out the transition area. So that the contour will become more rounded and more beautiful after the injection. So this is how I treat the lower third of the forehead. And then after that, I use the gauze to massage. Usually when I massage from the distal to from the proximal to the distal. So if you do the other way around, chances are you can push some of the product more to the entrance point, and then you will have nodules or more product at the entrance point. So in conclusion, Elanza is a collagen stimulating filter that provides both immediate correction and collagen stimulation effects, which enables us to deliver a more long-lasting result with precision. And then bone remodeling and the fat loss are major factors in the aging process of the upper face. So identifying the locations of volume loss are crucial for aging sign correction. And for the injection techniques, subciliar plan should be the managed injection plan with regard to the forehead reshaping and aging sign correction. Injection should be carried out with care to avoid uneven product distribution and vascular complications. Thank you. Now I give you the time to Isaac.
Hi, thank you. Thank you, Shang-Li, for that very informative lecture just now. And even I sitting here, I've learned even more things. So let me go on to the next slide. Okay, so just a brief introduction about me. So I am the founder and medical director of the Autism Clinic in Singapore. I have been accredited for Elanza and Silversoft in 2016. And I was also proud to be one of the first members of the Elanza Asia Advisory Board, together with Shang-Li in 2016. 4 years ago in WEM also, I had the honor of receiving a prize for the best before-after photo competition, where we combine Elanza with Silhouette Soft. So I'm also proud to be conducting regular webinars for Sinclair College. These are the awards for last year: Sinclair Top 50 APAC Clinics, and Top Silhouette Soft Clinic in Singapore, and Top 5 Elanza Clinic. So I also held a lot of live workshops before COVID, and now we are restarting. And I'm glad that we are going to be at Barcelona again, just in 2 weeks' time. So before we start, usually we need to go into the anatomy and understand why and how do we treat the temple. So before we start, there's a poll question now. So I'll read out the question. The approach to facial filler treatment for natural results using the lowest amount of filler is to start with the mid-face first. True or false? Please start clicking your answers. So the approach to facial filler treatment for natural results is to start with the mid-face. Oh, okay, so quite close, 51% to 49%. So 51% voted true and 49% voted false. And the answer is actually false, because usually we will start with the top. That means we start from the forehead and the temples first for the best results. So we will show you the anatomy and the science. So this is a slide and a paper by Professor Rulin Huang and Yun Xie, published in the Aesthetic Surgery Journal in 2017. So we can see that how do we define the temporal area? So the superior border will be the this superior temporal septum, and then anteriorly is bordered by the lateral orbital rim, and then inferiorly by the zygomatic arch, and then laterally by the hairline. So this area of treatment is always is a big area. So there's some compartments. So just lateral to the superior temporal septum is the lateral temporal fat compartment. And then inferior to the inferior temporal septum is the lateral orbital fat compartment. And then they can also be separated into the, on the right photo, we can see that they can also be separated into the upper temporal compartment and then the lower temporal compartment. So there are actually 7 layers in the temple, and this is also a diagrammatic illustration. So we can see that there is layer 1, which is the skin, and layer 2, which is the subcutaneous fat, and layer 3 is the STF, which is the superficial temporal fascia, and then layer 4 in the interfascial plane, and then the deep temporal fascia, and then the temporal muscle, and then the cranium. So again, these are the layers after being dissected. So the important layers that we want to talk about is, of course, in the deepest layer on the supraperiosteal layer, and also the interfascial layer, which is layer 4. Another important structure is the retaining ligament. So for which I would like to draw your attention to the orbital retaining ligament, which is also adherent to the temporal ligamentous adhesion at the near the tail of the eyebrow. So if you look closely here, we zoom in into the temporal area, and we can see that this part, the TLA, and then there is the, underneath that is the orbital ligament. So this is an important structure where I would like to place a little bit of Elonce in a small amount of bolus to support this ligament. Later on, we'll show you in a video. And if you place that ligament bolus properly, you'll get an instant eyebrow lifting. And the line of ligaments, so in a paper published by Cotofana and Casabona, we can see that there's an imaginary line of ligaments in the lateral part of the face. So it starts with the TLA, temporal ligamentous adhesion. As we move down to the pericanthal area, which is, there is a lateral orbital thickening. And we move down, there is the zygomatic ligament. So not to be confused with the ZCL, different, they are different. And then the mandibular ligament. So there is an imaginary line of ligaments where the usefulness of this is that the lateral to this is more mobile, and it can be, it's better to inject the fillers laterally and start there for a lifting effect. Then you will need less fillers in the medial aspect. So the first principle by Kotofana in this paper, understanding facial aging through facial biomechanics. So we can see that he and his panel of esteemed colleagues worldwide advocate injecting fillers of high viscoelastic properties into the superior temple first, because by performing that, we can reduce the mid-facial volume because of tightening and lifting effect. And we can also have a contouring of the jawline by repositioning the lateral ptotic tissues. And the same principle applies. Let's say you move the mid-face, you will approach the soothe fat pads first before your nasolabial fold. So when we approach nasolabial folds, we often do not directly inject into the piriform fossa first. We go for the assessment of the mid-face. And of course, when you want to treat the mid-face, you go for assessment into the temporal area. Principle number 2, deep first. So the first principle just now was a top first, and now we go deep first. So top first, deep first. And these are very important principles. If you do not take anything away from today, remember these principles and it will guide you along in your facial filler treatments. So deep first. So we always go deep fat and supraperiosteal injections first. For example, in the medial soothe, lateral soothe, in the deep medial cheek fat, or at the forehead area as well, we go the subclavian plane as Shang-Li has told us. So these are safer plane because the facial arterial vasculature, they travel a bit more superficially. So by treating the deep area here first, it helps to provide support to simulate like a bony support or a deep fat support for the overlying soft tissue structures. And then the surface volume coefficient, another paper published by Kotofana has illustrated that in the deep temporal fat area, the surface volume coefficient is quite high at 0.53 to 0.63. And for the soothe fat pad, it's about 0.93 to 0.95 here. So if you had a minimal amount of filler and you want to get best results, we will go for this paper. We will inject into the soothe area, we will inject into the deep temporal fat, and we'll inject into the deep lateral forehead compartment. So you notice they are all deep. And then the third principle, lateral first. So lateral to the line of ligaments, the lateral facial layers extend into the medial face. So the superficial temporal fascia actually joins into the SMAS, and then it also is continuous with the orbicularis oculi and the platysma inferiorly. So when you inject filler laterally first, and then you move on to the medial part, Casabona and Kotofana has found that by doing that, you actually need less fillers for the medial part. And that will help us to also respect this transverse facial septum, which is a newly discovered structure recently that is causing this effect of this worldwide pandemic. I would say after COVID, I think this is the next biggest pandemic of overfilling the mid-face. So lateral first, and you need less volume medially. So injection techniques. Firstly, why Elance? So Elance has high G prime, more than 1000 pascals, and the highest lifting power among all the fillers. So it corresponds to my principle of a minimal product and a maximum effect. So it prevents the effect of the overfilled face syndrome. And high cohesivity, so unlikely to break or migrate, even if you inject into layer 2, I feel that Elance is the filler of choice. And high viscosity at areas where the bony support is lacking, for example, at the gonial angle. I love Elance for that deep support of the bony structure support, and that lifts up the jawline immediately. And that we would like to show you next time in our lower face lecture. Elance itself stimulates type 1 collagen. Most of it is type 1. So initially it's type 3, and then it converts into type 1 after 6 to 9 months. And type 1 collagen is the baby collagen, which is the collagen that we all want. And the longest lasting collagen stimulator is Elance. It lasts longest in the market now. And it's great for patients with active lifestyles. For example, my patients who go for cardio and gym a lot, and they lose the facial fat a lot and very fast. So we see this video here. So this is a testament to how strong Elance is. Anti-gravity is able to stay in one cohesive structure, and it doesn't even drop even when subjected to gravity. So look at that. And the main principles for temporal treatment, I think a guiding principle is, let's say if you have a small area of concavity like superior parts, we do like the gunshot, the supraperiosteal technique. So one bolus deep in, and then we do the ligament lifting technique. If there's a big area of volume loss, then we will use the deep cannula technique in the interfascial plane. That is layer 4. And of course, another principle is we always want to treat the associated deep fat. So for the deep lateral forehead fat, please treat it as according to Shang Li's video demonstration, was fantastic. And then we treat the roof, which is the retroorbicularis oculi fats, and then the SUF. So all these are related. So we do not treat the temple as one area, but rather it is the whole face is actually continuous. And then use the principles: top first, deep first, lateral first. So firstly, gunshot technique with the retaining ligament leaf. So we will inject into the retaining ligament. So we palpate for the retaining ligament, and then I will lift the skin and inject a bolus, 0.1 cc's on the bone in a black dot. And then next to this first bolus, I'll inject 2 more small boluses, about 0.05 cc's. And then 1 arm and 1 over technique in the paper published by Fotofana, and this is a very famous technique. And then we'll inject deep with a long needle into the temporal fossa, and touching the bone, we will aspirate first before injecting about 0.3 to 0.5 cc's. I like to use my non-dominant hand to compress the superficial temporal artery, aspirate before injecting, and open the mouth to relax the temporalis muscle. And so if you look closely in the dissection, so there is the bolus, the arrow points to the bolus that where you're placing in this technique. And then in the deep cannula technique for a big area of volume loss, so I will inject a hydro dissection bolus. So I use lidocaine with adrenaline. I inject about 0.3 cc's to create a bolus, and that lifts up the skin and the subacute tissues so that I can directly access onto the bone and lift up the vessels. And then I puncture a 23G needle and then touch the periosteum with the cannula, and then you slide downwards into the temple. So you glide the cannula inferiorly and deeply, always trying to stay deep, and be careful not to let the cannula slide into the superficial layers. Deposit the Elance thin threads, 0.1 cc's of Elance in every cannula of 5 cm. So it's a very careful extrusion technique. So this is the roof fat pad, and we can see that just medial to the roof, you can see the vascular structures coming up from the supraorbital foramen. So just be careful when you inject the roof. And these are case studies. So this is the first technique, the orbital retaining ligament and supraperiosteal technique. So on the left of the photo, which is a patient right, we can see that it's untreated. And on the patient's left face, we can see that the tail of the eyebrow is lifted. There is a bolus there. And then there's also a bolus in the temporal area. And we can see that it created a lifting effect immediately as compared to the untreated side. So we're looking at less temporal hooding. We're looking at a raised eyebrow, a more refreshed show of the eyes and the pupil. So for mouth ptosis, we can even use Elance to treat. And this lady is 48 years old. And we can see that the treated part of the face, which is the left of the photo, we can see that the brow, again, is obviously super raised, and the lateral canthus of the eye is raised up. So the blue line is the lifted lateral canthus, and the red line is the untreated. And there is a difference of about 0.3 to 0.5 cm. And for this gentleman, 60 years old, even a very mature gentleman, we can also reproduce the same result. So again, I place the 0.15 cc's into the orbital retaining ligament to lift the eyebrow. and to reduce the ptosis effect. And then into the supraperiosteal region in the temple area, I will inject as well a 0.35 cc bolus. And this lady, I perform a full face rejuvenation. So, but for the sake of today, we will look at only her upper face. So she's 35 years old before treatment, and the below photo is 24 months after treatment. Total volume was used 11 ml of Elonze. So if we focus on the upper face, we can see that she looked very tired, very hollow, looks very fierce before treatment. And after treatment in the upper face, we can see that there is a lifting again of the eyebrow, and the temporal area looks fuller, so it gives you a nice heart-shaped face from the anterior view. And even in lateral view, we can see that her eyebrow and the periorbital area looks fresher. So we can see that she doesn't look so tired, and it makes her look fresher and feel more confident and feel younger. So, and then 36 months, so that is 1 year after the review of the 2 years, we added 4 ml of Elonze. And the bottom set of photos is about 42 months after the first treatment. So we can see that overall her face structure still looks pretty similar. Maybe she has lost maybe 30% of the effect of the Elonze in the first session. So we can see that Elonze itself has a very long-lasting effect on facial rejuvenation. This lady, 44 years old, and after 10 cc's of treatment, and this is the photo after 1 year, we can see that she looks thinner, slimmer, and more refreshed. Of course, a disclaimer, I think that she did lose weight. However, we can see that she looks way better than before. And the oblique view, again, we can see that the eyebrow seems to have lifted a little bit more, and the ptosis has reduced again. And her lateral canthus in the before photo looks to be pointing downward angle, and in the after photo, it looks to be a bit more horizontal or even pointing up. Lateral view. So again, we can see that the clear upper eyelid being shown. And this lady, 50 years old, so after 10 cc's of treatment, we can see that she was not treated in the central forehead, but rather at the temporal area and the lateral forehead. So we can see that the refreshment of her face, she looks younger, she looks more youthful, and yet she doesn't look weird or different. Again, oblique view, and we can see that the fullness of the temporal area and the lateral forehead fats, and her eyes just look a bit more fresh, has that bit of shine in the face, the glow. When you look at her, she looks much less tired and less fierce. Lateral view. Even for gentlemen as well, so we can look in the lower set of photos at the holding of the eyelid. You can see that it's much reduced in the after photo. So this was taken just 30 minutes apart after treatment of 3 cc's of Elonze. And this gentleman, 42 years old as well, we can see that the temporal area is much refreshed, and the eyelid is lifted as well, and he just looks fresher again. So the injection demonstration. So we palpate and then we feel that orbital retaining ligament, lift up the tissue, and we inject a bolus of 0.1 cc's to support that orbital retaining ligament. And then I move medially a little bit and inject 0.05 cc's. So we're all touching the bone. And then laterally another 0.05 cc's. And this is the supraperiosteal technique, the 1 up and 1 over technique. So we palpate the temporal crest and 1 centimeters up and 1 centimeters laterally, parallel to the lateral orbital septum. Touch the bone, aspirate first, and then we slowly inject about 0.3 to 0.6 cc's of Elonze with the needle not moving at all. You can see my non-dominant thumb covering the superficial temporal artery. And this is the deep cannula technique for a temple. So again, the temporal crest. So I will choose the area where I can reach both the lateral forehead compartment and the temporal compartment in one injection point. And then I will use the cannula to measure. Sorry for the sound. I think, can we mute the sound, Alex? Yeah, so I inject that hydrodissection bolus. So you can see that there's a bump, a bolus of the LA there. And then I use a 23G needle to touch the bone with the puncture. And then I use the cannula, touch the bone again. I point the bevel downwards so that all placement of Elonce is deep. And I slide it onto the, from the periosteal plane and deep into the temple area. So making sure that you cannot even see my cannula. You can see that I'm injecting in a retrograde technique of linear threads, and yet you are unable to even see a hint of a cannula from the skin of the temple. So I inject about 0.1 cc's per 5 centimeters of cannula, and Amanda later will show us more on the tips of the safe injection of Elonce. So after the temple is done, then I will move to the roof compartment to treat the roof fat pad, making sure with my non-dominant finger to prevent a extrusion of the cannula into past the orbital ligament, so that I stay with the cannula still in the roof fat pad. And then it's a very careful sculpting process to treat the area of the roof and also the superior temple area. And after every few 0.3 to 0.5 ml of Elonce, I always take it out and massage nicely to ensure no irregularities or no bunching of any Elonce anywhere. Still in the roof, you can see. So all the while, I'm always touching the bone and putting the bevel of the cannula downwards. Sometimes it can be a little bit discomforting, so I actually will use a nerve block for the supraorbital area. And now I'm treating the deep lateral forehead compartment. Okay, next. Okay, so conclusion. The treatment of the deep temporal and the deep lateral forehead fat has a high surface volume coefficient. So if you want to prevent overfilled face syndrome, you want to have the best results for the minimum amount, we will go for those areas. And top first, deep first, and lateral first. Lesser volume needed for your mid face, so lesser volume, you save the amount of Elonce needed. And by treating the associated deep fat structures like the roof and the SUV and the deep lateral forehead fat, we can get very good natural results. So the supraparietal technique has been found in a paper that it is more local effect. So it reduces that hollowness at the upper temple. But if you want restructuring of the lower face fullness, it's better to do the deep cannula technique. So you can read a paper by Kotofana. And always start with the upper face Elonce treatment for the most natural result. Thank you. So I'll hand over the mic to Amanda. She's a queen of collagen, and we are all very excited to hear from her. Thank you.
Thank you, Dr. Isaac and Dr. Shang Li. And that was very informative from both of you. A lot of good anatomy there and good injection techniques, which is very important for the upper face. So lastly, I'm the last speaker. I'll briefly introduce myself. I'm an Elonce International Key Opinion Leader. So I basically represent Sinclair Global, Sinclair Asia Pacific, and now Sinclair China. So they've all got me working very hard at the moment. As Shang-Li talked to you about the Alanze Experts Guidebook that was launched earlier in the year, I was very proud to be a part of that group of doctors to bring this book together. And of course, with Dr. Nicolau, Pierre Nicolau, who recently passed. I'm a cosmetic physician for over 19 years at Bioscore International in Melbourne, Australia, and I specialize in collagen stimulating injectables and thread lifting. I'm a fellow of the two main cosmetic colleges in Australasia. And yes, and you can follow me on Instagram. Today, I would like to start with talking about some benefits of why I love Alanze for the upper face. So I thought I'll start off with some positive notes before we jump into the adverse events topic. And then I will touch on the safety of Alanze and the complications that we face with dermal fillers, and how can we prevent these complications and how to manage them. And I will specifically be sharing 2 adverse event case studies to do with the upper face, which are quite interesting. And lastly, I would like to inform all clinicians that use Alanze how to report adverse events, because it's very important for Sinclair to monitor the safety and efficacy of Alanze for the future purposes and for everyone's confidence to use the product. So I'll just share some of my cases of the upper face. So when I first started using Alanze, I was very surprised at the natural seamless results that Alanze can do for the forehead, because it's such a thin area. You know, the tissue layers are very thin in the forehead. And we know that we've seen quite a lot of foreheads being treated with hyaluronic acid and of course fat injections, and they can actually look quite unnatural because a natural forehead tissue is actually quite thin. So by volumizing with something like Alanze, where you end up with type 1 collagen production, you end up with a very nice seamless result that doesn't look artificial. So as the Dr. Isaac and Dr. Shang-Li mentioned, it's quite common to treat the forehead and temple as a unit because they work in harmony together. Even in a very thin forehead, you can see Alanze gives that very seamless result. So this is one of my first cases of the forehead, which I was nicely surprised at the lovely result that Alanze can achieve. So it's a very nice product to use for the upper face. In terms of global rejuvenation, it's very important to treat the upper third of the face. Many patients would present with disliking, the lower face. So they'll always present with heavy jowling, and they seem to focus on the nasolabial fold and lower face. It's not very common for a patient to come and present, oh, I need my temples filled or my forehead filled. So it's very important as the clinician to do a full facial assessment. And we can see from this case here, by volumizing the upper third, it harmonizes the balance and the structure of the face. And if anything, her face actually overall looks slimmer. And you can see her eyes look more refreshed and lifted. Her eyebrows and even her upper eyelids look a lot less heavy. And this is the beauty of Alanze, is that you get the lifting from the initial volumization, but even more lifting from the collagen stimulation that follows. So I always believe that my patients look a lot better at 4 months when the total Alanze, the collagen has really taken place. This next lady was actually a lady that I presented in an upper face webinar with Professor Majala. It was a part of an anatomy series. So this lady was one of my models, where she actually had 9 mils of Alanze in one session. So normally I probably would break up her face in possibly 2 to 3 sessions in clinical practice. But because it was an upper face webinar, we focused on the upper face and temple and moved down the face. And as Dr. Isaac mentioned before, it's very important to treat the upper part of the face because of the lifting effect. We find that as we work our way down the face, we need less product in order to achieve a nice aesthetic outcome. So this lady there's lots of videos on this lady on the Sinclair College website, but this is her when we see the true result of the treatment. And you can see that her upper face, especially her forehead, is quite masculine and hard looking. So softening that area and volumizing it nicely with Alanze gives a softer, more youthful appearance. It's more beautiful to look at, and also it's anti-aging. So let's talk about the safety of Alanze. So we know that Alanze for many years has a good safety profile, has undergone lots of clinical trials and safety studies, and it's been on the market for over 12 years. But of course, with anything that we inject in the skin, there's always the possibility of adverse events. And the more that we do, the more that we're going to see them. That's the natural progression. Most adverse events caused from Alanze tend to be quite minor and related to injection technique itself, which is why today's emphasis is all about anatomy and injection techniques. And I will try to emphasize some of those during my talk. So adverse event rate for Alanze. So since the CE mark was launched in 2009, approximately 2.4 million syringes have been used, which is a lot. And the adverse event rate you can see is very low, so 0.0462%, 1 in 2,165 syringes. And as you can see, the adverse event type, majority are nodules, swelling and inflammation, which is, I find with Alanze, you get more swelling and inflammation compared to hyaluronic acid, but it just comes down to reassuring the patient. And of course, bruising is part and parcel with injections. And these are sort of common adverse events that we see with any dermal filler. So it's very important to notify Sinclair of adverse events because we want to continue to monitor the safety of Alanze. So let's look at the complications with fillers, but first we'll do another poll question, number 3. So a nodule is it secondary to a chronic non-specific inflammatory immune reaction, or is it related to a technical error, and does it increase in size? Okay, so actually a nodule is more related to a technical error, whereas most of you have answered the first answer, which is mostly relating to granuloma. So I will talk about now the difference between a nodule and granuloma, which can be confusing. Okay, so first of all, these are how we split up adverse events. So we've got early events that occur post-injection. So these typically could be infection, swelling, bruising, irregularities, and of course, vascular events can happen almost immediately. And then we've got the delayed events that we see weeks and months to years, where we can see nodules that are delayed, but also foreign body granuloma. Of course, sometimes infection can be delayed as well. And also some skin changes too. Most causes of complications are due to technique driven. So whether our technique is sterile or unsterile, of course, if we're placing too much product and overcorrecting. So with Alanze, we always say that, we don't want to overcorrect because we've got to allow the collagen to regenerate and grow. So especially in younger patients, we direct our users of Alanze to almost inject maybe 70 to 80% under correcting because we want to allow for the collagen production. In an aging rejuvenation patient, so typically someone over 50, it's probably safer that you can inject to correction, but younger patients, we have to be mindful that we don't want overfilling. And obviously improper placement of the product in the layers. So if Olanzapine is injected in the dermal layer, which is too superficial, we see quite a lot of nodule problems, and especially in the tear trough. If it's within the orbital rim where there's little to no fat, where there's lots of muscular contraction, we see many problems there as well. And we don't want to put too much product in one bolus or per linear thread. So the rules of Olanzapine is small boluses. Whether you would like to put multiple boluses in the one area is okay, but not just one big ball. And tiny linear threads will actually lessen nodule formation. And of course, we don't want to inject in vessels, which is why it's very important to use the proper technique instrument, whether that be needle or cannula, and also in the right layer. So a nodule is probably one thing that we more would commonly see with injections of Olanzapine. And these are usually due to a technical issue. So if you get a nodule, it's usually your fault, unfortunately. So we saw a lot of nodules early on in the early days of Olanzapine where the injection was too superficial. So we do not chase lines with Olanzapine for necklines or perioral lines and so forth. The most superficial layer that we like to inject is layer 2, which is the superficial subcutaneous fat. If we see a nodule, it actually appears quite early. Okay, so when that initial swelling occurs from the inflammation of Olanzapine, nodules are technical errors are seen quite early. So it's more common in tight or superficial areas, and it's really due to large bolus sizes or too much product in the one injection point. When I first started injecting Olanzapine, I felt that in a few of my patients, I was getting quite a few nodules in the pre-gel sulcus, for example. And this is an area that's very tight and where there's a lot of dynamics between muscles in that area. So since I've decreased my bolus size, so instead of 0.2, I've lowered it to 0.1. And whether I put multiple points of 0.1, I don't exceed that amount of volume. And touch wood, that's actually overcome my adverse event rate with nodules in the pre-gel sulcus. And, but nodules are seen with other products as well. But with Olanzapine in particular, we find too superficial placement and too bigger bolus size or product in that one area and in muscular areas. They tend to be quite firm and they can be present as a little bit whitish as well. So as opposed to granuloma, so granuloma is actually quite rare. So even though you see photos and you hear about it, it's quite scary, but it's very rare. And in my experience with Olanzapine, I've actually personally only seen one that I've dealt with very recently. The picture on the bottom with the discoloration is a lady that actually I was looking after who had Olanzapine done overseas. And once I read the adverse event report by the practitioner, I felt that there was too much product too superficially in that area. So I suppose there was a high risk of such a big reaction. But this lady presented 6 months after her injection treatment with Olanzapine. With a lot of skin discoloration and hard nodules. So because a granuloma is actually secondary and a chronic non-specific inflammatory immune reaction. Okay, so when we look at the cellular makeup, it's composed of multinucleated giant cells. So it's different to a technical nodule. Okay, so a granuloma reaction usually is delayed. So it doesn't happen straight away. It can happen 6 months to 24 months post-injection. So the one patient that I'm dealing with at the moment actually presented 1 year after her Olanzapine injection. And her nodules most look like the lady in the above picture where they were kind of firm and large nodules, but no skin changes. That's probably the more common granuloma reaction that you'll see. Whereas you can get skin changes, which I haven't seen. I've only seen in this lady one time. So it can be a delayed reaction. Granuloma tends to happen in all the injection sites, so not just in one area. So a technical nodule is usually in one zone or one area, but granuloma is basically will flare up everywhere where the product has been administered. Some feel that it could be triggered by a systemic bacterial infection. And therefore it's very hard to predict who's at risk of granuloma. And they typically can grow in size. And as you see from the picture, skin discolorations are not uncommon. They're divided in types of granuloma based on clinical features. And we see granuloma is seen with other foreign bodies. So any other filler can cause granuloma reaction down the track. So it's not just Alanze or other collagen stimulators. Normal fillers also can get granuloma. So when it comes to nodule and granuloma, essentially nodule, technical error, practitioner's fault. Granuloma, unfortunately, patient's fault. Okay, but we can minimize the granuloma reaction by safely placing small amounts of product. And especially we don't like to use lots of product superficially, because if one was to develop a granuloma, it's going to happen more, the features of granuloma will be more severe if there's more product superficial. So preventing complications. So of course, with preventing complications, it's important to select patients that are appropriate for Alanze. And yeah, as we know with Alanze, it's very versatile for global rejuvenation in young patients and older patients. We need to have a good treatment plan. So we need to establish which areas of the face that we want to treat, and also start to plan amounts and volumes that we want to use per session. Okay, so, and we have to consider plane of injection, and also are we going to use sharp or cannula technique? So it's good to plan out amounts of Alanze, and also have that conversation with the patient. You know, I want to make sure that my treatment is safe. So I would like to do this amount the first time. Let's review you in 3 to 4 months with the intention of building on this problem area. So you don't need to get to 100% correction in one session, because the beauty of Alanze is that the results are so long lasting that we can afford to continue to improve the patient's aesthetic journey without having to start again from zero when we review them at 4 months. And good injection technique. So as the other doctors have mentioned before, low pressure, small bolus injections, the correct level of injection per area, and also selecting the appropriate instrument. And of course, we all need to know our anatomy. So I'm sure you all would like to rewatch all the anatomy that was previously spoken about on the Sinclair College. And preventing nodules. So yes, as I said, always inject slowly with low pressure and avoid large volumes. So the rules are no bolus should exceed more than 0.1 to 0.2 mils. And the retrograde linear threads, because they're more superficial, we want to make sure that each linear thread is 0.5 to 0.1 mil per linear thread. So especially if we're trying to just improve skin quality without volumization, your linear thread should be 0.05. Whereas in the preauricular area where we want a little bit more volume, we can go a little bit deeper in the subcutaneous fat and bring the linear thread volume a little bit higher. But we must make sure that we're stopping injecting before our entry point, because we don't want product to seep superficially at the entry. And avoiding large volumes essentially is less tension on the tissues, so less chance of nodule formation. And of course, muscle contraction can also lead to building up of the product in one area, so increasing the risk of nodules as well. And granuloma, as I said, we really don't know who's at risk of granuloma until it happens, unfortunately. But with any slow resorbable product, we want to make sure that we don't use so much product, especially in the superficial layers of the skin. So small volumes are preferred. And it's always good to not inject product where there's previous permanent filler, or because in case of a granuloma reaction, we don't really know which one's causing what. So anyone that's got a permanent implant, we tend to avoid using Alanze in these patients. And the contraindications of Alanze is essentially anyone that's sensitive to the components of the product, history of anaphylaxis or for severe allergies, any acute or chronic skin disease. So we don't want to treat on an area that's inflamed or query infection. Patients with keloid susceptibility or scarring, and no one who's on current cortisone treatment. We don't want any active infection. And autoimmune disease, this is a tricky one. So of course, there's now a whole range of autoimmune disease that affects different parts of the body, but I treat patients very individual. So if the autoimmune disease is affecting their skin and you're unsure about the inflammatory response or the collagen, this is where you have to be a little bit cautious. But if the autoimmune disease is unrelated to face or their skin issues, then it's okay. And we've got to look at if the patient's condition is well controlled on medication. And we don't encourage them to change whatever they're doing that's contributing to controlling the autoimmune disease. So treat every individual on the individual basis. And of course, we want to not inject in the areas that we can't use Alanze. So typically around the mouth area, perioral area superficially, and also the periorbital region where there's little to no fat. And of course, the glabellar region in general is an unsafe area. So managing complications. Before we go into that, we've got the 4th poll questions. Okay, so for overcorrection with Alanze, when would dispersion of Alanze with saline be the most effective? Would it be the first 10 days post-treatment, between the 10th day and 5 weeks post-treatment, or after 5 weeks post-treatment? So most of you answered correctly, which is the first 10 days post-treatment. That's correct. So saline would be effective at this point, and I will explain that further along. Okay, so any inflammatory complication from Alanze or injection of filler should really be treated, like every component of the problem that presents itself should be treated individually. So if you suspect infection, and if there's any pus present, obviously do a swab, and antibiotics would be an option. And of course, if there's inflammation and swelling, you might want to prescribe some steroid treatment, orally short term. For overcorrection, going back to the poll question, so we talk about the mode of action of Alanze and the foreign body response. So we know that if we get anything early with Alanze, we can actually disperse the product with saline quite effectively before that collagen capsule starts to form. So before the encapsulation of the foreign body. So we can actually disperse the CMC gel with saline. And for overcorrection, we can repeat it quite often, so weekly, to actually remove the product. If the patient presents a bit later, so after the 10th day and the 5th week, we'll start to see the type 3 collagen capsules. So the encapsulation would have occurred, and the beginning of type 1 collagen would start to appear at the 5th, 6th week. So we can still disperse with saline, but you might want to introduce the steroid, intralesional steroid as well, to stop the foreign body inflammatory reaction. And so after the 5th week, this will become a little bit more difficult because the type 1 collagen is starting to form. And therefore, overcorrection after the 5th week is more treated like a nodule. So when we look at the nodule, that's, as I mentioned, is more of a technical error. It's very difficult to know that you've created a nodule because when you first inject the patient with Alanze, there's obviously inflammation and swelling from the treatment. So usually patients will not notice a nodule. Usually it would be, the earliest would be after a few weeks, but typically they might present as early as only a month. So, and you might only see a nodule when the patient presents for review at 3 to 4 months when they come for their next treatment. So initially, the protocol that I use in my clinic is that if you can get it early, which is unusual, so in the first 10 days to 5 weeks, you can try saline first and with firm massage, and that can be done quite frequently. But if you find that it's unsuccessful or the nodule presents later than 3 months, your best interest is probably introducing the intralesional steroid to stop the inflammatory response. So we usually continue treating the nodule until it's barely visible or gone. Some patients don't mind the fact that it might be still palpable, but as long as it's not visible, it's okay. With steroid, we have to be mindful, especially for the forehead, that we don't want to cause any lipoatrophy. So therefore, we need to use very small amounts within the nodule and then monitor that. And with steroid, I would be reluctant to treat too often. I would say that 2 weeks would be the minimum. And especially for forehead, it's very common to get the fat atrophy in the forehead area. Other areas of the face don't tend to be as high risk. With granuloma, similar to treating nodules, you would use intralesional steroid to each granuloma nodule. So same method. If the nodules are widespread, you might want to consider oral steroids if it's just flared up and presented itself to you. And so usually 2 weeks of steroid treatment according to body weight. And if you think that there's a need for antibiotics, antibiotics can also play a part in decreasing the granuloma reaction. So vascular occlusion. So the protocol for vascular occlusion for Alanze, and this is a question that comes up a lot because people associate Alanze as a non-dissolvable filler. So they're quite scared if they get a vascular event. So basically the protocol for vascular occlusion is to hit it with everything but the kitchen sink. So you've got a list of things. So essentially it's about increasing blood flow to the area. Okay. And we still, hyaluronidase is still effective for Alanze vascular occlusion because we want to open up all the barriers of the blood vessels and allow for more blood flow. So it's easy to apply a hot, warm compress, vigorous massage if you suspect vascular occlusion. It wouldn't hurt to give the patient aspirin orally. You do your hyalase protocol like you would with HA filler. The pentoxifylline and the sildenafil. Now, these are oral medications that can actually help increase blood flow to the body and improve the oxygen to the body. Both drugs are used for peripheral vascular disease and for pulmonary hypertension. So these have a place as well. Not many people use GTN patches or discs anymore, even for HA fillers, but I guess if you have it, you can use it. Steroids can play a part to decrease inflammation and to help relieve obstruction as well. And also if there's skin changes or necrotic changes, you can consider hyperbaric oxygen. If there's any skin changes or wounds that need taken care of, you might have to provide surgical debridement and treatment of the wound. And of course, if they end up with scarring at the end of the day, you have to deal with the scarring to help the skin changes. So I'll go through now 2 case studies. So one will be a common one and the second one is an uncommon event, which is quite interesting. So this is a forehead nodule, a non-inflammatory nodule. This is my patient. So this has happened to me a handful of times actually when I do a forehead Alanze injection using a cannula. And because I would like to share it with you because since causing this a few times, I didn't want to be known as the queen of nodules. So I have really tried to overcome causing this problem with injection technique and asking advice from my peers. So this is, for me, like has come up after I've overcome my pre-gel sulcus nodules. Then this has happened to me a few times. And essentially, this lady presented 1 month post Alanze. So she was pretty good because she rang up and said, oh, the rest of my forehead has settled, but I've noticed that, the lumps where Dr. Amanda has entered have in fact grown bigger and have not settled. And so because it was reasonably early, like 4 weeks, I thought, okay, why don't we just try to break up the nodule with saline, because she had a very thin tissue. I was afraid of the fat atrophy on the forehead. However, after doing this and reviewing her a week later, there was minimal effect and she was quite distressed. So I implemented the steroid methylprednisolone injection, and I reviewed her 2 weeks later. And I found that it reduced significantly when I administered the steroid. And she didn't get any issues with lipoatrophy. So this is her after 2 intralesional steroid injections. And as you can see, look, she's quite happy at this point, but I've reassured her, I'm happy to monitor her. I'm happy to repeat the injections if she doesn't develop any side effects or skin changes. So they're quite simple to treat, but the earlier they present, the better. So some tips to overcome this problem that I've implemented since it's happened to me a few times. I was using a 22 gauge cannula, but now I decreased to 25 gauge because I want to make sure that the tract, because ideally you want the product to stay in the plane and not to seep superficially at your entry point. So what you saw was entry point nodules. So if I decrease the size of my cannula, the tract is more narrow to prevent leakage. I actually now don't add lidocaine to my Alanze that I'm using for the forehead because it allows the product to remain in its original form, which is quite stiff. When we add the lidocaine, it becomes a little bit more watery. So now I prefer to use the Alanze more neat for the forehead. And also making sure I stop injecting well before my entry point. So in this picture, I've actually just marked out the lines. So I've marked out the temporal crest, which is where I enter from, and I've drawn lines to tell myself where to stop injecting. So just be mindful of your entry point. And when molding the product, I think when I initially started doing forehead injections, I got overly excited and was over massaging because I was worried that I was going to get irregularities or lumpiness. But now I know that we just can mold gently with Alanze. And if you're going to massage away from the entry point and occlude the entry point either with a gauze or a Q-tip if you're going to do so. And I've tell all my patients now that if they do notice that the swellings at the entry point increase or don't settle after 2 weeks, to call the clinic and notify and come in, because it's much easier to deal with an early nodule than one that presents late. So now we're going to go through a temporal vascular occlusion. So one of my Melbourne peers was kind to share his experience, not a nice experience, mind you. And this was, I think, late last year, because I presented this case in Dubai for Train the Trainers event for Sinclair. And my colleague was very kind enough to put all the information last minute together. So let's go through it together. So he treated a 36-year-old fit and well occasional smoker, past history of rhinoplasty. She already had past treatments with him with Alanze, Sculptra and laser therapy. She wasn't a new patient. He decided to treat her temple area with Alanze using a 22 gauge cannula, and technique was in layer 4. So between the superficial temporal fascia and the deep temporal fascia. And at the time of injection, didn't notice any signs of occlusion when the patient left 30 minutes after treatment. Now, this patient actually contacted the clinic with some skin changes, query bruising in her left temple. But this was on the 19th of December when the treatment was done on the 16th. So you can see that there's a 3-day delay here. Okay, so when the doctor took the history, The patient said that there was no pain 16 hours following the treatment, but 24 hours after noted some tenderness, but they were both on both sides. Already noticed that there were some skin changes on the left side of the temple with some slight dusky appearance. Now, the patient remembers being warned about changes of skin, but she thought that she was overreacting and didn't want to bother anyone at that point. And so 48 hours later, her left side was more tender and more throbbing sensations were detected. She decided to take Panadol and went to bed. Okay, so 72 hours later, this is when she contacted the clinic because she had increasing pain. So this is how it looked on 72 hours post-treatment. Okay, so on examination, you can see that the skin changes, the dusky appearance of the skin and the texture of the skin. You've got the tiny little pimples there on the surface. Capillary return was delayed more than 12 seconds throughout the affected area. And so immediate management was aspirin orally, heat packs and massage, and the Hyalase was administered 750 IU 6 times every half hour. And prednisolone was given orally as well. Because of the skin changes, oral antibiotics were commenced at the same time, and the patient was monitored for capillary refill. Okay, and so it started to return very slowly at this point. She was referred to our Alfred Hospital in Melbourne for hyperbaric oxygen therapy. The patient had 12 sessions over 6 days. So this is her progression. So the steroids were continued for 4 days and then decreased, weaned off after that. The antibiotics were continued further for 10 days. The aspirin was also continued. At this point, this is where I got involved, and Dr. Francisco de Mello in Dubai got involved. And Dr. Francisco recommended that the patient takes the sildenafil and the pentoxifylline orally as well. So his advice was just throw everything at this patient that you haven't done already. However, the pharmacist didn't have the pentoxifylline, and the patient actually didn't want to take the Viagra. So in the end, she didn't take any of those tablets orally. So continued monitoring, wound care and debridement were followed through at this point. So you can see day 1 after the adverse event management was put in place, day 6, day 10. So day 10, you can see less scabbing of the skin clearing there. So this is the patient 22 days post managing the adverse event. So it actually looks like the tissues, the tissues were saved, they're viable, they're not necrotic, although signs of scarring are present. And the doctor then proceeded to do superficial fractionated lasers treatments for this patient to help with the scarring of the skin. And this is the outcome 4 months post adverse event. So I actually would say that this is a good outcome for this lady. So she's very lucky in this case. So in terms of the temple area, especially what happened in this case, the doctor's intention was to administer the Hyalase layer 4 with a cannula. However, we can't forget, because tissues, all the layers of the temple, they're still quite fragile structures. So even a blunt cannula can pierce through layers if you're not careful. So if we're too rough, even if we start in the right plane, we might not always remain there. So we have to consider that when we check our layer 4, we must always recheck. Don't think for 1 minute that once you're in there once, you're there forever. I always recheck my layer 4 every time I come back with my cannula and before I put more product in that area. So obviously with cannula size, a 22 gauge cannula is thick enough that it probably is difficult to breach the muscle. However, a 25 gauge cannula is quite fine. It can actually become more superficial as well. So we have to be very mindful that although we're using blunt instruments, with force, we can still pierce through layers. So don't think that a cannula means that we're always going to be safe. So that would be my take-home message with the temple area. So in summary, Alanze, we know, has a good safety profile with a low rate of adverse events, and most adverse events are basically due to the injection itself, and nodules would probably be the most common technical error. And several steps should be taken to prevent the complications using Alanze. And if they do occur, there are specific approaches and protocols that we can follow when they happen. And adverse event reporting. So it's very important for every practitioner that undergoes an adverse event that we do notify the vigilance team at Sinclair, because Sinclair have to continue their monitoring of Alanze safety and efficacy. And this is how we become confident to keep using Alanze, is because of all this information that we are updated with. And thank you for listening. And I think we're going to go into the Q&A session now.
Thank you, Dr. Amanda. Yes, indeed, we're now going to begin answering the questions submitted during today's presentation. As a reminder, you can still submit questions through the question panel in your attendee control panel. So the first question we have is for Dr. Lin. For the forehead, can I inject in the layer 2 with Élancé?
Okay. For the layer 2, it's relatively a layer that is not that safe, especially for Caucasian skin. The skin of layer 2 is relatively thinner for Caucasians. So you have to be very careful. And also we need to pay attention that the muscle layer is on a layer 3, but they also have some of the some muscle fibers that go superficially to the skin for the facial expression. So you have to be very careful if you are injecting a layer 2. And a layer 2 is not the main compartment that we loses volumes in the aging process. So I would not recommend layer 2 for a Alanze injection. That will also increase the risk of nodules and irregularity in case of uneven distribution of the product. And even you distribute the product very evenly, there is also a chance that during the facial expression, you can compress these products, and then you will cause irregularity through the facial expressions. So layer 4 is still the better plan for injection.
Thank you, Dr. Lin. Now we have a question for Dr. Isaac. For the temple, which technique do you prefer and why?
Oh, okay. So for the temporal techniques that I've shown, those are the two main ones that I use. And I would prefer the deep cannula technique in layer 4, as Dr. Shang-Li has spoken about, because I find that with that technique, we can reach both the lateral forehead and the roof, and also reach into the temporal area. And also by volumizing the layer 4 in the temple, I have also seen results that the jawline also will be lifted. So I can foresee that the lifting power of Élancé is able to lift up the jawline. So you need less volume in the mid-cheek area and the gonial angle area, and also at the jowls. So layer 4 and the deep cannula technique is preferred. However, that one needs a little bit of skill. So please look for your local reps and trainers for some training sessions on that. Thank you.
Thank you, Isaac. We also have a question for Dr. Amanda. Which areas of the face are nodule more common?
I think in the past, when practitioners first used Alanze, we saw a lot of nodules in the periorbital region where there's little to no fat, and around the mouth and the lip areas. So we always say that these are the areas that we don't use Allanze. But for the common areas that we do say that Allanze is safe for, I've seen mostly in the pre-jowl sulcus, as I mentioned before, where now I've decreased my bolus size to overcome that adverse event. And of course, if you chase lines superficially, you're going to see more nodules. So we've got to be mindful of layer of injection and bolus size and linear thread volumes. And therefore, if you follow the rules, you'll see very little nodules, adverse events.
Thank you, Dr. Amanda. We have one last question before we wrap up due to time. The question is, what is the advantage of Élancé over HA in high-risk areas like forehead and temple?
Are you taking this one, Shang-Li?
Okay. First, I'm not so sure. Élancé is in the forehead injection or temporal area is high risk because for it doesn't. It's actually not related to which kind of product you're using. It's actually how you are using it and what injection plan you're placing the product, especially for the vascular complication. For as long as you're not in the right plan or not properly injecting the product, it can all increase the risk of vascular injection. So it's not quite associated with the product itself. Instead, it's associated with the injection technique and the injection plan. So some people may think if anything happens, we can dissolve the product with hyaluronidase if you are using HA, but actually, to be honest, we are not injecting the product to dissolve it. So we have to make sure what we are doing and know we are doing, and then every product have its safest way to use it. So that's my suggestions of using Élancé to treat the forehead and temporal area.
Thank you, Dr. Lin. So if you have any other questions, please use the contact form of the Singer College. We had a lot of requests for the expert guide. So I'm going to put back the slide with the QR code. So if you want to request an expert guide, please flash this QR code or go directly on the website to request it. You can also contact your local sales representative. Please note that this webinar will be available on demand in the Singer College webinar section within the next few days. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you could complete that and provide your feedback. On behalf of Singer and our presenters, thank you very much for joining us today and have a great rest of your day.